Hello everyone, my name is Jay Khatri. I'm an interventional cardiologist who specializes in complex PCI as well as CTO intervention. And today what I want to talk to you about is the ReCross microcatheter. It's a dual lumen microcatheter that I found very helpful in my practice. I'll go through some slides explaining to you exactly what the device is, and then we'll go through some real world examples of how I've used it in my practice. And hopefully you'll find this helpful and give you some ideas on how well you could integrate this into your practice as well. So what are the main indications? We all use microcatheters to perform coronary interventions. So this is 2 over-the-wire ports. And what I want to explain through the course of this presentation is what's unique and different about this and what makes this such a powerful tool for complex coronary intervention. 2 over-the-wire ports gives you the freedom of maximum support as well as guide wire control through 2 over-the-wire lumens instead of 1 being rapid exchange. You can exchange these wires at will. You can reshape wires at will. You can have opposing exit ports that are 360 degrees of freedom to interact with a lesion. And it's super low profile, small enough to trap in a 6-French guiding catheter. Here's a schematic of exactly what the catheter looks like. So there's both a blue as well as a white hub on the back end. The blue hub has a stylet, which is used to help enhance the deliverability of the device to the area of interest. The stylet is removed to be replaced with a guide wire as needed. The working end of the microcatheter has 3 exit ports. There's an end port, which is connected to the white hub. The white hub also is connected to a side port, which is 12 millimeters proximal to the end port. And 180 degrees opposed to this side port, there's another side port that's connected to the blue hub. So the blue hub comes out of the 8 millimeter side port, the white hub comes out of the 12 millimeter side port as well as the end port. So this allows 3 points of exit for guide wires depending on which port and which side port you're exiting. The device, as I mentioned before, has a very low crossing profile. It's small enough to trap in a 6-French guiding catheter, which is quite unique and can be quite helpful in situations where you weren't anticipating on doing something quite this complex. The device itself has some unique construction that improves its ability to be delivered through challenging tortuosity, calcium, and tight lesions. There's braiding throughout all the way to the tip. And there's the stylet, which I mentioned, which enhances the rigidity of the device to improve the deliverability through the lesion. When do we use this and how do we use this? These cartoons give you some nice overviews of applications that I think are particularly helpful. So unique to CTO in particular, I think this is probably what we'll spend the majority of my talk reviewing cases about. So for parallel wiring, when a guide wire has tracked subintimally or extra plaque, what that really means is that we've punctured the proximal cap incorrectly, and you can use a dual lumen microcatheter, particularly in this case a ReCross, to be very aggressive in terms of repuncturing the proximal cap in a different way so that you can perform parallel wiring to try to track plaque and re-enter distally. The device can also be used in cases where we've already crossed the entire length of the CTO and are now subintimal beyond the distal cap and perform a wire-based reentry. The side ports are really helpful for this, for reentry. And in conjunction with the reentry aspect, we can use the side port to evacuate hematoma that might be created by the wiring attempts from earlier in the procedure. So evacuating the hematoma before doing a wire-based reentry. Obviously, any type of dual lumen microcatheter can provide tremendous anchoring for side branch anchoring to puncture a blunt proximal cap of a CTO. It can be helpful to access an important side branch after crossing a CTO. It can be helpful to rescue an important side branch. And so I'll show you some real world examples of all of this as we move forward through the talk. The first and probably the most powerful role for ReCross is in parallel wiring. And what do we mean exactly by this? So you approach proximal cap of a CTO and the first guide wire bounces off the proximal cap and enters an extra plaque space. The natural instinct in this scenario is to pull the wire back and try to repuncture. The problem with this is that it actually removes some of the important information that we need to track the artery. By leaving the guide wire in position, we now have important information about exactly where we do not want to go with any subsequent punctures. And not removing this guide wire prevents any blood from accumulating and forming a hematoma. So I think that leaving that wire there is very important and can actually facilitate the subsequent parts of the procedure. So with a dual lumen microcatheter, now you have the opportunity to repuncture in a slightly different way. The idea is to puncture the proximal cap in a way that deviates away from where the initial wire puncture went, which you see in the center panel. And once you've made this new puncture, then you can track either the same wire or a polymer jacket wire through. The fact that we have two over-the-wire lumens means that we can seesaw back and forth. And I'll show you an example of what I mean by seesawing in a real-world example coming forward. So the first case I want to share with you is a case that was done at an outside institution, a patient that had circumflex in-stent restenosis CTO, and the operators were able to cross the CTO quite readily, but they couldn't get any balloons or microcatheters to follow their guide wire. And they appropriately thought that perhaps they were behind metal. And so what they did is they left the first wire in place and they took a second wire without a microcatheter. And unfortunately, the second wire, although it's in parallel, it's right on top of the first wire, and it didn't really improve anything. So basically, both of these wires are going underneath metal, making it balloon and microcatheter uncrossable. So he came to see us for a second attempt, and this is what we did. So in the left panel, the first wire immediately went underneath the metal, as it had happened in the first operator's experience. And so we put a ReCross microcatheter in there. And the idea with the ReCross is we use the second port to puncture the CTO in a way that deviates away from the first wire. And this may take a little bit of effort, a little bit of time, a little bit of trial and error to definitely see some deviation. But the whole idea is to see the second wire leave a gap between the first and the second crossing. And you can go back and forth until you see this gap. So ultimately, we see that the wire is starting to deviate away from the first wire. And that's what you want to see. You want to see that there's a different path that's been taken by the second wire. So now this gap that we see here means that the second wire has punctured the proximal cap in a slightly different way. And then when we went back in with a conventional microcatheter, I left the first wire in position. And what I want to show you here is that there's this persistent gap between the first wire and the second wire. The second wire, which was introduced on the ReCross microcatheter, took a path that was better, that was free of the metal and allowed for a conventional microcatheter to cross. And you can see here, I left the second wire in position and put a balloon on the second wire. You can see again, there's that gap. The gap was produced by the fact that the second wire was purposely deviated away from the first wire and away from the metal. And that allowed for a successful completion of this procedure using a dual lumen microcatheter. What about a de novo lesion? So here's an example of a CTO on a post-CABG patient. This is a relatively short segment CTO of the circumflex. The proximal cap is blunt, and there are important side branches at the distal cap that we need to manage and make sure that we don't lose anything. So the first thing that we did here is we took a conventional microcatheter with a wire and pretty quickly found that we were spiraling around the vessel, likely in an extra plaque space. The natural instinct here is to pull that wire back and try to probe again. But quite honestly, I think that's a really counterproductive thing to do because now this wire is marking where we don't want to go. So taking that wire out is honestly making the case much more complex than it needs to be. So I think that leaving that wire in place is actually pretty helpful. And in this case, what we did is we removed this conventional microcatheter and swapped out to a ReCross so that we can reapproach the lesion and try to puncture the proximal cap in a deviated course. So in this fluorosave, you'll see there's a ReCross microcatheter. The first wire is still in position. And now all we're trying to do is puncture the proximal cap in a different way, a way that's deviating away from the first wire. And that's all we're trying to do. There isn't a lot of importance paid to where the side port is oriented. That really makes no difference. All we're using is the ReCross to deliver a second wire without losing the first wire's position. We're using the first wire to mark where not to go. Now you can see that there's this deviation and the second wire just pops into the lumen. But this was all made much more confident and feasible because we left the first wire in place. It would be very hard to know that the second puncture was different and unique without having that first wire left in place. And so this is just sort of a retrograde angiogram to show that the second wire truly did re-enter and we were able to complete this case without any major issues. Here's another example of parallel wiring using the ReCross microcatheter. This is a patient with an RCA CTO that's relatively short segment, and there's a side branch at the proximal cap and relatively calcified distal artery. So this is the first attempt. So this is a conventional microcatheter and a guide wire, which very quickly gets extra plaque and subintimal and starts to spiral around the artery. Again, the natural instinct is to pull this wire and try to redirect, but I think that that's a mistake. I think the important thing to do is to not lose this important information. We know that this wire seems to be underneath the lumen, so we know that we need to go above the first wire. So I like to leave this wire in position, replace the conventional microcatheter with a ReCross. So in the first panel on the left, we'll see we're going to take a second wire through the ReCross with the first wire left in position. All we want to do is make the second wire go above the first wire. And if we can get that wire to do that, it's usually going to be successful. And you can see that that's not what happened. You can see that the second wire actually went underneath the first wire. We know that that's not correct. But the nice thing about with a ReCross is they're both over the wire lumens. So now I can take the first wire out and replace it with a different type of wire, or the same wire with a different trajectory. So this is what you see in the middle panel. In the middle panel, we take the first wire back and redirected it with the second wire left in position. And now the second wire is the guardrail with the first wire being redirected. And you'll see that it deviates quite a bit from the first wire. And that's all we're really trying to do, is make sure that we deviate. And as long as we deviate, you can see that it's taking a completely different course than the first wire, and it's tracking the calcium nicely. And then in the right panel, you can see that this redirected first wire has now re-entered the true lumen distally. So this is a nice example of seesawing with two different wires, using both over the wire ports, with one wire being wrong, then the second wire being wrong, then the first wire being redirected using the second wire as a reference to enter the true lumen. So this is a beautiful example of parallel wiring using two different wires through the ReCross over the lumen, over the wire ports, to swap out wires and take advantage of the fact that we have two over the wire lumens to attack the lesion. What about a wire-based reentry? So we know that once you cross the CTO, the wire may pop into the true lumen distally, or it may remain in a subintimal position, as you can see in the cartoon on the left. Now, in the subintimal position, we have to find a way to get back in the lumen, and a wire-based reentry is definitely feasible, and you can use the side ports of the ReCross to help facilitate this. And this can also be further enhanced by using aspiration through the side port to evacuate any hematoma. If we can evacuate the hematoma, that will make the target of the lumen larger relative to the hematoma and improve the chances of a wire-based reentry. This is a case that we did. This is a patient who has had two prior failed RCA-CTO interventions. He comes back about 3 months after the last procedure for a reattempt. And the case started out reasonably well, where we did an IVUS guided puncture of the proximal cap, and we used a guide wire to track the vessel. And we did a re-entry distally. But what we found is that our re-entry was really quite unfavorable because it's too far downstream. So in these IVUS panels, you can see that in panel A that we're completely extra plaque. In panel B, we're also extra plaque with the lumen beneath us. Panel C, we remain extra plaque. And way out where D is where we finally re-enter the true lumen. So, I mean, this is not a good result for the patient clinically. If we were to stent this, the clinical benefit would be quite low, and there would be quite a high risk of the vessel restenosing, because we would have lost a bunch of side branches. So we wouldn't accept this. We would want to do a wire-based reentry, hopefully closer to panel A, so that we can resurrect as many branches as possible. So in this case, what we did is we left the first wire in place and placed a ReCross where that plaque was that we wanted to puncture. And now we'll use a penetration wire through the side port to puncture that plaque. And seeing this deviation between the first wire and the second wire is really what you want to see. That means that your second wire is puncturing into a space that's quite a bit different than the space that was created by the first passage. And once you've performed this puncture and see this deviation, you can track a wire out into this new puncture and hopefully track the vessel. So you can see how this wire frees up and just tracks the artery. So this is a wire-based reentry. and this is the completion angiogram. So you can see real carefully here, we've got much of the branches back now from this wire-based reentry, and above the lumen that we've created, you can see that false channel that was from the initial track. So you can use this to do a wire-based reentry to be more selective about how many branches you can potentially resurrect by your reentry, as opposed to a random reentry very distal into an artery that might lose a lot of important branches and limit the clinical efficacy of the procedure. So in conclusion, I would tell you that ReCross is a super helpful microcatheter because of the fact that we have 2 over-the-wire lumens with 180-degree opposed side ports. We can use the side ports both for parallel wiring, redirecting wires. We can use the side ports for evacuating hematoma. We can use the side ports for a guide wire reentry. Overall, the utility of the device is quite impressive, and I would encourage you to try to implement the device in your practice to see how you can put this to good use. And hopefully the cases that I present with you will give you some good ideas for where it might be helpful to use.